This conference will now be recorded.
Hello, everyone, and welcome to one of our quick sessions in which we summarize together one of the talk articles. And today we are going to discuss a very nice and chit chatting talk article. It's talking about the Bartholin cyst and abscess, and I know that most of you are going to enjoy it because it's like revising together. How should we deal for Bartholin cyst and abscess? Very quickly, just to remind you, where is the Bartholin gland? The Bartholin gland is located at 4 and 8 o'clock positions at the base of labia minora, and it has a duct, and this duct opens in the vagina. The main function of this gland is to lubricate the vagina, so it helps in not only during the sexual intercourse, but for the natural lubrication of the vagina, which, by the way, it has immunological function. Okay, as you can see here in the picture, this is where the porcelain gland and the duct is going to be here, and it will open in the posterior aspect of the vagina. So this duct, when it comes blocked with trauma or infection or edema or whatever, this will cause the dilatation of the duct leading to cyst or abscess, either this or that. There are some risk factors for this to happen, like nulliparity, sexually active women, especially under the age of 40, because they are very vulnerable for STDs, previous history of vulvar surgery or trauma, of course, and very specifically FGM. The organisms responsible for this condition will be mainly E. coli and Staph aureus. Yes, sometimes gonorrhea can play a role, but it's not the commonest one. So always keep in your mind E. coli and Staph aureus. I'm talking about SBAs here, guys, even for part one. If we have any candidates from part one, this is mainly part one questions. Okay, do we have a differential diagnosis? Of course. Your patient is going to tell you that I'm having a pain, I'm having a swelling, I'm having something that's causing me discomfort, and I don't know what's going on, and it's not going away. It has been like a week or two, and I think it has been the same size. It's not red, it's not painful, but it's unilateral, or it has been in one of the sides of my labia, and I'm just feeling discomfort. This is mainly a cyst, porcelain duct cyst. But when we have some signs or symptoms of inflammation, um, tenderness, erythema, fluctuation, redness, hotness, and so on. Now we're talking mainly about abscess. So what else can happen in this area? We have something called cyst of the canal of Knock. This is a soft cyst and very small one. It can cause by the entrapment of peritoneum in the round ligament. So it won't be exactly in the same site of porcelain cyst. It will be a little bit higher, a little bit inside of the vagina, but it's one of the differential diagnoses. What else? We can have epidermal inclusion cyst. This is found in the labia majora, but it's mobile and non-tender. Why so? Because it's not related to the gland. It's from the sebaceous glands in the epidermis. So when it gets obstructed, it will form this inclusion cyst. Also, it's very small, usually non-tender and mobile. This is very important characters for this cyst. We have something called hydranoma papilliform. This is also small nodules arising from the apocrine sweat glands, and mostly, guys, those cysts are uh, self managed, or they go away by themselves. So they are not going to be having a chronic presentation. That's why we don't fear them. Mucus cyst of the vestibule is also one of the superficial cysts that can happen in the labia minora or the vestibule. Skin duct cyst, which is a very important one, is usually will be found proximal to the urethral meatus, not in the same site of the porcelain cyst. It will be here, next to the urethra. And It also will happen when you have an inflammation in the skin duct, or inflammation in the gland itself. But its site is very, very characteristic. So I don't think you are going to misdiagnose this. Okay, how we are going to manage Bartholin cyst or gland? We have mainly two routes, either conservatively or surgically. Surgical management can be outpatient or inpatient. How can we say we are going to do so or so? I'm going to tell you about it. The commonest forms of management in UK, mainly via the use of balloon catheter or marsupialization. But in UK, mostly they prefer the word catheter procedure because it's outpatient. The pain score is very less, and it costs less, which is very important, and it does not need hospital stay. So not only we are saving money, but also we are having reduced risk in contracting hospital acquired infections, which is very important, very, very important. On the other hand, marsupialization or the inpatient management have higher pain score, of course, but definitive management, less recurrence, and it costs a lot, mainly because of the overnight stay. Do we have conservative management? Yes, we have. We can tell our patient that she can try the sits passes, compresses, analgesics, and we are going only to prescribe antibiotics when we have signs and symptoms of apparent inflammation. Cysts does not need antibiotics. In the majority of patients, they do not need antibiotics. Even abscesses, by the way, when they are very small, and this is the first time she's having this abscess, and she's not pyrexic, she's not having general malaise, she's not having signs of toxemia, you can not prescribe her antibiotics. This was mentioned in the strategy, but it's not mentioned here in the talk. Without with or without cellulitis, when you have pyrexia, this is an indication of antibiotics. If the cyst or the abscess does not improve with such measure, we can offer her, of course, the surgical options. Surgical options can be outpatient or inpatient, as I told you. Now we are going to talk about the outpatient options. Balloon catheter. Balloon catheter is one of the famous. We will need just to make a small incision over the most fluctuant part of the cyst, and then put the uninflated catheter. Then we are going to inflate the catheter or the balloon of the catheter, this one, with saline. Mainly they are about 2 to 3 milliliters. And if the patient is having some pain, or she's having, uh, doctor, I'm starting to feel a little bit of discomfort, you can draw away 1 milliliter. Okay, what is the function of this balloon? The balloon works like obliterating the space. This is one. Number two, it's going to help us make epithelialization of the inside of the cyst, so that we are going to form a fistula. Okay, this is iatrogenic fistula. We need this iatrogenic fistula. Why? Because we have a block in the duct. So it's like I'm forming iatrogenic duct. Okay, so what are the advantages of this method? First of all, it's cheap. It has a low recurrence rate, which I think it's good for an SBA, 12% at 12 months, 12 for 12. Very well tolerated. You can even fix it if you feel that it's movable, or the patient is telling you, I'm feeling that it will slip. You can apply one or two sutures to fix it. But on the other hand, it has disadvantages. Like what? The risk of premature expulsion if you don't fix it. The insertion itself can be painful, and many patients have latex allergy, and this catheter is formed of latex mainly, right? So always we have a pros and cons. So think about it and counsel your patient about pros and cons. The second one is the Jacobi ring catheter. Jacobi ring catheter is uncommon procedure in the UK, but it can be useful in resource poor setting. Like you don't have the balloon catheter, this one, it's not available. And I'm not aware of marsupialization technique. I do not know how to do it. And I remember that I have read about um, just doing what they call needle aspiration. Needle aspiration is very poor technique. It's very simple, yeah, but it's very poor and not recommended. So what I can do, I can bring a catheter like this, okay, and do an incision as we said before, and insert my catheter. So I'm doing a form of another fistula, another form of fistula, okay, but it's like let's say a cheaper one, or uh, let's say, yes, it's a resource poor technique. This is a resource poor technique. You are mostly going to use 7 or 8 centimeter French tube, T tube, okay, and you will do a small cutting in it, and then you are going to put it inside the cyst like this way and close the ending and let it be for some time. They say like 2 weeks, okay, and it will form the epithelialization and the fistula as we said. However, it will require 2 incisions and it will be very painful, of course, because you are inserting a foreign mass inside a healthy tissue, like, or a live tissue. Even even after all this, there is a patient satisfaction better with Jacobi ring more than the balloon catheter. It's not my word, it's the studies results that Jacobi's ring catheter have better patient satisfaction. Okay, the third technique is sclerotherapy. Sclerotherapy is by applying a chemical destruct like alcohol or silver nitrate. The the main um, the main result will be destruction of the epithelial lining of the Bartholin duct cyst or abscess, but it's not common practice in the UK. Same thing, you are going to insert a gouge needle into the cyst at the point of maximal fluctuation. You are going to aspirate the contents, then inject the alcohol or the silver nitrate by silver nitrate stick. And in the case of alcohol, the healing is going to take a week and it will cause less tissue damage. The recurrence is about 8 to 10% within 6 to 7 months. It's a little bit high. There is a risk of tissue necrosis and hematoma, of course, dyspareunia, definitely. Destruction of the gland surface, for sure. So that's why it's not very common in the UK. Silver nitrate going to need 2 week healing time and a very high recurrence rate, 3.8 in 2 months only. It can cause also burns, scarring, edema, and pain. Not only this, the stick is removed after 3 days. Why? Because this is how it works. You are going to insert a silver nitrate stick into the cavity and leave it to do the chemical destruction of the epithelial lining. And when you remove it after 3 days, you should see some necrotic tissue attached to the stick. So I think it's very, very painful. If you can imagine it, you are going to find it very painful and very destructive also. And I think it's not only will be destructive on the cellular level, it will be also not cosmetically good. Now, the inpatient or day case surgical management, which is, of course, the very famous marsupialization. The things good about this management is that it has low recurrence rate, almost 0% at 6 months and only 10% at 12 months. But, however, it's not cheap It's not easy, and it needs general anesthesia. So I'm talking about doing something that needs hospital stay. Not only so, it's not the best thing for a woman with comorbidities, right? But it is the recommended treatment for recurrent cysts and abscesses. So when you have a case with recurrent cyst and abscess, don't think about any other thing but marsupialization. And when it's recurrent cyst after marsupialization, you are going to need excision of the gland itself. So in case of marsupialization, the idea is what? The idea is to open the cyst or the abscess and clean it, of course, and destroy the locules if we are talking about the abscess. Then we are going to hold the cyst wall or the abscess wall and suture it with the healthy tissue outside the cyst. I'm going to I think I have a picture here. I don't know where it is. I think I have it. Anyway, the cyst wall and the mucosa will be sutured with interrupted absorption sutures all around the gland opening. It's like, let's say, turning your socks uh, outside. You know, when you turn your socks outside, it's just flipping your socks outside. The same, the same. So we are going to flip the cyst wall and mucosa to the outside and suture it all around the gland. Okay, what about the post-procedure care? I think you all know it. It's a simple analgesia. You should keep the perineum clean and dry. Please wear and change the sanitary towels regularly. Avoid intercourse for 5 days if marsupialization is undertaken. Wear loose-fitting clothes and underwear. And the most important one, please don't forget it in Part 3 stations, you should provide your patient with patient information leaflet and contact details for any emergency thing that can arise. This is very important. Don't forget to tell her, okay, I'm going to give you a patient information leaflet for whatever suspected or a complication that can happen, or how can you deal with it, and when you should come to the emergency gynecological unit. They talked about the cancer risk in Bartholin absent cysts. It's up to 5% only of vulvar cancers. Most common type is a squamous cell carcinoma. When we should um, not suspect, when we should think about Bartholin gland cancer. When I'm having a postmenopausal patient with recurrent abscess or cyst, when I'm having a presentation of firm, fixed, irregular shaped swelling, this is when I should take a biopsy with or without excision. Okay, a firm or fixed or irregular shaped swelling is very prone to be a malignant lesion. So early recognition of this condition is very important, very, very important. Okay, last but not least, the excision of the gland. When we should do excision of the gland itself? When we have a reoccurring cyst or abscess despite marsupialization or word catheter or other techniques. The high chance of blood loss makes us think about it many times. Why so? Because we are talking about a place have a blood supply from the udendal artery directly. Okay, and the pain. Tell me about the pain. Udendal nerve also. So the risk of hematoma and dyspareunia is very high. However, it can be our last resort. How can we do it? I think we should see this video quickly. It will be better than if I told you. Okay, we are going to palpate the mass. We are going to infiltrate our local anesthesia. I'm sorry, anesthesia. Then we are going to do our opening with to be very careful, very careful not to hurt the gland itself because it will be very vascular. So dissection here is the key for a perfect Bartholin gland excision. The dissection. Careful dissection is your key to do a successful operation. As you can see here, they are trying to dissect it without injuring the gland itself. Then once you have dissected carefully and successfully, the gland will be out in a minute. Okay, and that's it. And you can put your gauze, put your drain, and close. You can use Alice or you can use I think Alice is good. As you can see, one, two, three, and the gland is out. And that's it. But don't forget please to put to make sure that you are doing good hemostasis, okay, or you are going to face uh, uh, 2 or 3 days post-operative hematoma, and it's going to be very painful. So a good hemostasis is crucial. Then you are going to put your gauze and your drain and close, and that's it. This is the end of the talk article. It's very nice, I think, very small also. And thank you all for attending here today. Thank you so much, guys.
This conference will now be recorded.
So again, my friend, hello and welcome. We choose to start with the light topic first, okay, and then gradually go up to the most important one, and that can be a bit of, you know, um, reach one with details. Okay, now we will discuss the premenstrual disorder, including premenstrual syndrome and premenstrual dysphoric disorder. Okay, so we had a guideline for that, right? Yes, we have. And it's very important on the levels of the part 2 and part 3 exams. All postgraduate obs and gynae um, certificates, they must test this topic. Why? Because it's very common, right? It's something that we see every day in the clinic. You have in the gynae cases at least, okay, 4 out of 10 they have PMS symptoms. 8% or 1 in 10 will have almost the severe form of it, right? Okay, so what's new today? This guideline, it just discuss with you guys more, or this article discuss with you more of the details about the why is a cause, okay, of the PMS, the theory behind it, and the evidence-based treatment. I can see it's a more of organized, okay, guideline, okay, with a little bit increased detail. This little bit increased details will be important in the questions of single best answer if you are setting a written exam, and it will be important if you have a structured discussion, okay? So the examiner may ask you, if you have a PMS discussion, may ask you about the underlying cause or what you think is the theory of the PMS, okay? So let's start together, not to waste any time. So my friend, what is the difference between the PMS and the BMDD, or the premenstrual dysphoric disorder? Simply, the PMS is something very common, and it can appear, you know, and as we said, 90% of the female in the childbearing period, they have somehow symptoms of the PMS. Official diagnosis of the PMS affect around 20 to 40%, while the severe form of PMS, which called the premenstrual dysphoric disorder, is around 8%. Okay, so this is the simply, okay, the main difference. This is one thing. So it's different in the symptom severity, it's different on the impact of life. Which one is more severe? Of course, the premenstrual dysphoric disorder. And the impact of life also in the premenstrual dysphoric disorder patient, okay? So the symptoms of both manifest mainly in the luteal or post-ovulation phase of the cycle. Okay, so how can I differentiate? I have made this table, guys, for you to easy, differentiate between both of them. And you should know that common symptoms of PMS like low mood, mood swing, headache, food craving, fatigue, tiredness, breast tenderness. This is the PMS symptoms, but the PMDD is psychological, more psychological, like depression, anger, anxiety, severe mood swing, irritability and loss of confidence, panic attacks sometimes, difficulty sleeping, suicidal thoughts, physical, which can include as well breast tenderness or abdominal bloating. So, my friend, as you can see, this poor female who had a severe form of the PMS, which we called it PMDD, is a lady who suffered a lot, okay, almost half of her life. So, how we can help her? We can help her by first understanding of the underlying cause. The underlying cause theory is divided into three out of this took article. One is abnormal sensitivity of the central nervous system to female hormone. Two is the genetic factors. Three is the psychological factors such as stress. Okay, so I need to comment in short about each one of them. The abnormal sensitivity to central nervous system of the central nervous system to the female hormone is mainly towards the one of the metabolite of the progesterone. And if you can see here, guys, with me down there will be, yes, Dr. Say, I'm recording. So there will be a start of the metabolism of progesterone in the body. So progesterone with the work or the act of 5-alpha reductase enzyme, it is turned in another metabolite. Okay, this is the 5-alpha dihydroprogesterone. Okay, and then it is again under another enzyme, okay, turned into the allopregnanolone. Okay, so the allopregnanolone, this is the one, okay, that seems guilty in the pathogenesis of the PMS. Okay, so the allopregnanolone, this is not only presented in the body, and they have found it have affected the mood and the behavior of those females who are having this PMDD and PMS, but also they have found that there is genetic tendency. Okay, so the genetic tendency came from some of the genes like ESR1. This is estrogen receptor alpha dysregulation, okay, and overexpression of another gene, which is called the extra 6 comps enhancer of DISTI. Okay, this is a complex of gene also found in this woman. So there is a problem, a genetic problem, and there is abnormal sensitivity to the allopregnanolone. So understanding of the pathogenesis and how does it work on the brain and how it lead to the change in the behavior is our main gate or our main way in how to treat the PMS. Okay, so we will find that simply there is two areas on the brain, okay, that mainly will be responsible about the behavior, like the hippocampus, okay, and the amygdala in the limbic system, right? I know I'm taking you to a lot of the physiology here, but I'm trying to make it easy, guys, for you as per the TUG article. Okay, so there is two neurotransmitter in our body, on our brain. One is called GABA and one called glutamate. Okay, so in order to have a healthy, psychological um, life, and we have a stable mood, and we have enhanced cognition and sensory processing as well. Okay, this is need a balance between the two neurotransmitters, the GABA and the glutamate. What happened in a woman with PMS or BMDD? What happened is imbalance between the two of them. So if the imbalance happen between two of them, okay, so what can happen? What can happen is if the glutamate, which is the excitatory one, increased, there will be anxiety, insomnia, reduced brain neuroplasticity, and will be also increased pain sensitivity. If the GABA, which is the inhibitory one, increased, that is anxiolytic, and it will improve sleep, and it's neuroprotective, and it reduces the neuroinflammation and reduce the pain sensitivity. So if the woman had the glutamate high, what we need to do in order to balance? Simple. What do you think? What I need to do? I need to bring the GABA up, right? I need to increase the GABA level. Does this make sense? I hope so. Okay, so now I understand that there is a problem on the level of the metabolite of the progesterone, which is the allopregnanolone, and I have also imbalance between the neurotransmitter in the brain, which is GABA and glutamate, and their receptor mainly in the limbic system. They have hippocampus and the amygdala. So this is why those women have the symptoms, the psychiatric symptoms or the psychological symptoms, and it can be more severe that in some cases they think of suicide before the time of the period. Okay, so we need to help this woman in trying to return this balance into normal. Okay, right? So we will work on both pathways. How? Before I go to the treatment, I need to tell you guys, remember the diagnostic approach to the BMDD. And this is for all my friends in the OSCE exams in part 3. Okay, why? Because you will have the case in front of you and you speak to her. You need to go through the diagnostic approach correctly. Okay, so number one is we have prospective. Prospective means in the future, not retrospective. Prospective recording of symptoms over 2 cycles using the DRSP7 or similar chart. This can be possible question in the written exams to document severity of symptoms, cyclic relation to menses, and symptom-free period before the next ovulation. This symptom diary need to be completed before you start a treatment to avoid masking of symptoms. So if I have a woman and complain of symptoms of PMS and it's not diagnosed yet, and I want to make sure of the diagnosis before start treatment, what do I need to do? I need to have a prospective recording of symptoms over 2 cycles and using the chart that it came in the TUG article. This is the DRSB7, okay, chart. Symptom diary need to be completed before treatment, please, okay, in undiagnosed patient. Symptoms must be severe enough to affect the quality of life. So a very logical question that I ask the patient is, how does this affect the quality of your life, right? Then rule out medical or mental disorder with similar presentation. Use the DSM-5 criteria to diagnose the BMDD. Okay, what is the DSM-5? Anyone of you have experience with this, the DSM-5 criteria? Simply okay, I'm trying to make it very simple for you guys. The DSM criteria, it's a criteria used to diagnose psychological disorder, okay? And the recent one of it, okay, is that have been released or have been adopted recently, the 5. It's DSM is stand for Diagnostic and Statistical Manual of Mental Disorder. Okay, this is, guys, this is have been done or have been adopted by the American Psychiatric Association. Okay, so when you find the DSM-5, okay, like for example, in a case, in the case paper or in the referral form of a patient, so you should understand that this is a way of the diagnostic and the statistical manual of the mental disorder. Our psychologists, they are very familiar with the DSM-5 criteria, okay, and they will just apply this criteria to the woman, okay, and make sure that the woman is really diagnosed and she is matching the diagnostic criteria of the BMDD. Okay, so now this is to make sure of the diagnosis. Anything else? Yes. If you are in doubt, please remember the rule of GnRH agonist. Okay, so why I will use a GnRH agonist if I'm in doubt of the diagnosis? This is a trial of medical ovarian suppression with the gonadotropin releasing hormone that can be helpful by temporarily eliminating the ovarian hormone secretion. So we will test the response in this woman. Okay, this is if you are in doubt. Are we clear so far, my friend? Any questions so far in the diagnostic approach to the BMDD? Hello?
Dr. Rabah,
Yes,
uh,
please.
so you said that one of the diagnostic tests is the GnRH agonist
This is
to
if you
suppress
are in doubt.
in doubt.
Yes.
So, doctor, if we give it and the patient become iatrogenic menopause, it can lead to overlap between the menopausal symptoms and premenstrual.
Yes, you are great. So I'll tell you, dear, if you use it for a short time, okay, it will not be enough to cause the symptoms of the perimenopause, okay? But if you use it for a longer time, then you have to give ADVAC therapy, okay? So your trial will be with the ADVAC therapy. For the diagnostic purpose, usually it will be a shorter trial, 2 to 3 months only. This is if you are in doubt, but mainly the symptoms will be clear. You will not, yes, dear, you will not need to go through this before the psychological assessment. Yeah, I have a very good question also from Dr. Ifat. That's the DSM-5 diagnostic criteria. Look, dear, okay, this will be like a big questionnaire, okay? A psychologist, they will discuss with the patient, they're not a psychiatrist, okay? Somebody who is trained to complete this DSM-5 form, okay, will speak to the patient, and this is not only for the PMS, by the way, this is for the mental disorder generally, okay? They will try to find if the patient is matching the criteria. What is the criteria for the BMDD? I'll tell you. Let's say A, B, C, D, E, F, G, okay? One by one. A is definite temporal relation to menstrual cycle, okay? So that's mean you have to make sure that her symptoms is related to the menstrual cycle. Understood so far? Is it easy so far? Okay, I'll move. And if you have any question, guys, please don't hesitate to ask. Okay, B and C is minimum 5 out of 11 symptoms, which is at least one core symptoms. Okay, the core symptoms here, as you can see, this is symptoms occur in the ovulatory cycles. Symptoms are not specified. They may be somatic or psychological. The number of symptoms is not specified. Symptoms are absent after menstruation and before ovulation, of course. They must recur in the luteal phase because you have to make sure that the woman had her symptoms in a relation to the menstrual cycle, and it's post ovulation and relieved by the menstruation. And the woman, when she is before the ovulation, means the first 2 weeks of her cycles, she is fine. Clear? Simply, this is how to make sure that this is the core BMD symptoms, okay? And the symptoms must cause significant distress or impairment, for example, to work, school, social activity, hobbies, or interpersonal relationship. Okay, so she will come to you in the, for example, in the face-to-face exam, or sorry, on the role player exam, and she will say, I almost losing my work, my relationship. At the time, I ruin my relation with everybody. I can't tolerate anybody to speak to me. I fight all the time. Okay, so of course, this is severe impact on the life and severe impact on the, it's called impairment of relationship, right? So for a woman to have a criteria on the DSM-5, she must have 5 out of these 11 symptoms. Okay, clear? Okay, so next, symptoms to interfere markedly with usual activities. This is easy. Work, so school, social relationship. E is symptoms are not a mere exacerbation of an underlying condition. So we need to make sure that she is not a chronic depression patient, or she is not a chronic anxiety patient. And usually those type of patient, if they have chronic mental problem, they will have all the time. They will have the problem all the time, not relation to the period, right? Not attributed to physiological effect of substance or other condition, like the patient is not drug abuser, she is not on other medication, or the patient have, for example, endocrinal problem like thyroid dysfunction. Okay, because if the patient, for example, is hyperthyroidism, might be irritable. Okay, so PMDD should be confirmed by prospective daily symptom diary for 2 consecutive cycles. Okay, this is the G, this is the last thing. So if the patient simply, dear, is fulfilling those criteria of the DSM-5, she will have the diagnosis of PMDD. Easy? Clear? Okay, so the next box, number 2, is giving you the criteria again. It is the same thing. Okay, marked affective liability, marked irritability or anger, marked depressive mood, marked anxiety, tension, same thing. Okay, difficulty in concentration, lack of energy, marked change in appetite, feeling overwhelmed or out of control, a change in sleep, physical discomfort. Okay, so this is simply the criteria. This is a tick boxes, it will be this DSM 5 form is a big form, so many pages is there, and there will be boxes, and they will tick 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 tick, okay, by the practitioner, so they will find how many symptoms this patient have to match the diagnosis of BMDD. Clear so far? Okay, so let's have a look to the treatment. What do you think? This is, my friend, the evidence-based treatment. Okay, so what is the evidence-based treatment here? Evidence-based treatment is the treatment that you will advise based on this is based on the latest evidence, the evidence that they have found to the relationship between the sensitivity to the hormone and the genetic predisposition that make a specific woman more, more sensitive, okay, to a specific treatment. So, number one, first line treatment. I need you to remember it's 4-line treatment, okay? 4 lines of treatment. The number one is the first line and it's the longest line. Okay, shall I offer everything to the woman in number one together? Of course, no, it's just a trial, but you will choose which one is more suitable to your specific patient, okay? And this is considered as first line treatment, okay? So, number one, we are trying to reduce the effect of hormone fluctuation on the neurotransmitters by lifestyle modification. Lifestyle modification, like advise the woman to have complex carbohydrate diet during luteal phase, aerobic exercise, yoga, meditation, exposure to sunlight, stop smoking and alcohol. Okay, so this is easy, lifestyle modification. Along with cognitive behavior therapy, CBT. Okay, neuromodulators can be used like what? Like selective serotonin reuptake inhibitor, okay, and selective norepinephrine reuptake inhibitor, either continuous or to be used in the luteal phase. Okay, so how can the neuromodulation can help the woman? Okay, why I'm giving the woman the serotonin, okay, reuptake inhibitor? They have found that when a woman have increased level of serotonin in the brain, okay, this by the way can be achieved by exercise and can be achieved by diet as well, okay. Some diet increase the level of serotonin in the body, like for example a tryptophan rich diet, popcorn, complex carbohydrate, whole milk, um, tuna, peanut. Okay, so those things that we use, most of them we are using them like some snacks. Okay, so this can be very helpful to increase the serotonin level. That's why we're happy when we take those snacks. Exposure to light, this is also, okay, will increase the serotonin effect. It's very, very common in cold countries, okay, like for example in the UK, when the winter there is less exposure to sun, and in some countries, especially the Scandinavians, they have the sun disappear in the winter, increase level of depression, and it's called seasonal depression. And in the Scandinavian countries, higher rate of suicide. Why? Because the sun can help your body make serotonin, okay, by exposure to light. So it's very, very healthy, okay. Mood induction, stress reduction, okay. So this can be done by use of the selective serotonin reuptake inhibitor, okay, and even the norepinephrine reuptake inhibitor, the SNRI, okay. So this is used in the first line therapy. This is not a second line, or some patient when they don't like to use the hormonal management or the hormonal approach, they have a good response to the SNRI. Also, they have found that it's reduced the body sensitivity to the progesterone. Okay, so it's very, very effective, in tackling the problem of the BMDD. Okay, so guys, as everybody sees the screen clearly, please, if you see the screen, tell me yes. If you can't, please let me know. Okay, yes, thank you very much. So guys, if anybody of you have a problem with the screen or with the sound in the meeting, please log out of the meeting and then log in again. Okay, it's mainly an internet problem. I'm sorry for that. Okay, so my friends, we have the common treatment, okay, which is the, as we said, the first line of treatment, the SNRI or the SSRI, either luteal phase, means that to be used only in the second half of cycle or continuous. Okay, this is according to the preferences of the woman, right? Okay, so what can I use for a woman not planning pregnancy? If a woman not planning pregnancy, okay, so we can start for her combined hormonal contraceptive, right? And this is to reduce the fluctuation in the hormonal level. The combined hormonal contraceptive can be used, and for example, okay, we can use something like the Yasmin, okay, or the anything from the new form, but take care that it's a little bit increasing risk of VTA. Okay, so the COC can be used in a short hormone-free interval, means use it for 24 days and only 4 days hormonal free. This is to reduce the fluctuation of the hormone. And sometimes you can even describe it as continuous, okay? And the continuous makes more stable mood, tricyclic pattern, okay? So the patient have it for 3 months and then off 1 week, 3 months and off 1 week, and so on, or 3 cycles, I mean 3 cycles of the drug and off 1 week, and so on. Okay, so this is one of the ways according to the patient preferences and your own selection of the patient. What else? This will be a combination between the levonorgestrel, okay, and the ethinyl estradiol patches, okay, or tablet. Okay, so the woman have a problem with the progesterone. How can I provide her with the progesterone? Okay, yes, because the estradiol is going to help with the symptoms, but I can't give a woman with a uterus estradiol unopposed. I must give her something to protect the endometrium. So the levonorgestrel here will be to protect the endometrium. So give her estrogen in the form of ethinyl estradiol, 20 microgram, and this should be continuous for 4 months without any break. Okay, so the woman will use the ethinyl estradiol for how long? For 4 months. Is there any break in between? No break. Okay, she will have the levonorgestrel for the endometrial protection. Are we clear so far? So all of this comes in the first line treatment, and the first line treatment I can use combination between lifestyle modification, CBT, neuromodulation, or hormonal if the woman does not want the pregnancy at the moment, and the hormonal can be COC or estradiol plus Mirena, right? Are we clear so far? I hope we are. Okay. Okay, so my friend, what is the second line treatment? I'm sorry for anybody who can't see the screen. Please, please just try to look out, okay, and then look in again. Okay. Okay, what is the second line treatment, my friend? The second line treatment is simply think about combination therapy with SSRI and COCP. Okay, so I'm using one of the choices in the first line, the drug choices in the first line, but in combination. Okay, so combination therapy with SSRI and COCP, estrogen therapy, estradiol patch. This is 100 microgram, or estradiol gel 3 milligram plus micronized progesterone. okay? And the micronized progesterone is the one with the least effect on the PMS symptoms or the BMDD. So the woman will use 200 milligram for 12 days during the luteal phase, orally or vaginally, okay? So she will not use the micronized progesterone continuous, okay? So is it clear so far, guys? Is the woman going to use it continuously? No, not continuously. Okay, so what will be used in the luteal phase? I can use the micronized progesterone, or as alternative, what can I do? Mirena. Yes, excellent, well done. Okay, so this is the simple management of the second line. Okay, so I have a woman who who have used the COC and is not helpful. Okay, the combined COC. And then she came to you, she had the CBD lifestyle modification, but no effect. Okay, so next, what will be the action? Next will be, I would suggest the second line treatment. Second line treatment means that I will go to the combination therapy plus the SSRI. Okay, so I can use this estrogen therapy, for example, okay, estradiol patch and or gel plus the micronized progesterone or Mirena, okay, just to protect the endometrium. So how about the third line of treatment? Third line of treatment, this is to also aiming for reduced fluctuation hormone level by using the GnRH analog, okay? Okay, so I have here a note on the GnRH analog. Okay, so the GnRH analog, my dear friend, when I use it in a female that is not menopausal yet, okay, that will be inducing menopause to her, right? It's a medical menopause. Then how can I use it? This is a precaution and the information that you need to know regarding the GnRH. The GnRH analog is either used in the form of injection. Okay, can you see it here? This is the most common one we use, the liberalized. Okay, and other mode or other form is the intranasal. Intranasal is most common because it's most easy one, right? So I just give you some of the, famous brand. How can I use it? It will be used as a trial, okay? And the trial for 2 to 3 months to find out if there is symptom relief or not. Okay, so if there is no relief after 3 months, what shall I do? If there is no relief after 3 months, what shall I do? Stop, right? So it failed the trial. Consider that the cause is something else, cause to her symptoms is something else. Okay, no, the woman find it's good and it's helping her and she's fine. So she said, can I continue on this nasal spray or the injection for forever? What you will say? What do you think? The problem is effect on the menopausal symptoms and the bone mineral density, right? So if the GnRH is used more than 6 months, what you will advise? What you will advise is add back therapy and regular measurement of the bone mineral density by the DEXA scan. Okay, so it is not a solid no, it's a form of counseling. And my dear friend, you have a station, very famous station on the PMS, and each time we come with different details, okay, from the role player and her request is different, because they are testing your knowledge of counseling, how to counsel, right? So if the woman choose to use the GnRH analog, okay, which is the, as we said, this is the one of the lines of surgery, that lines that carry risk, okay, risk of the bone mineral density and the menopausal symptoms. So add back therapy is very important, okay, and measurement of the bone mineral density is very important, okay. It's clear so far? Okay, my friend. Yeah, so this is very important. So I give you here a note, okay, that this will be, my dear friend, okay, this will be decided after the initiation of the treatment as a trial with the consultant. Why? Because, and with the follow-up, okay, because as long as the woman benefit from a treatment, and as long as the woman have no complication of it by follow up and making sure that it's not affecting the bone mineral density, okay, then she can continue on the treatment, right? So each time she will come for the follow up in the future, she will need a review, okay, and a discussion between, again, either continuation or not. But if there is a cut off, or there is a time when we say you must stop now the GnRH, it's based on the follow up and in the future, dear, okay. There is a famous question, my dear friend, that comes to ask you about the bone mineral density or the DEXA scan. How frequently this should be done for a follow up this woman? How frequent? Annual. The DEXA scan is done annual, okay. Yes, it's mentioned in the guideline, okay, so it's annual. So this woman, she will have a yearly follow up for measurement of the bone mineral density and review her case, and as long as she benefits from the treatment, she can continue, okay. Okay, so here in the notes, my friend, as you can see, also from the guideline, so sorry, from the TUG article, the box number 5 is to give you, uh, you know, different agent of the SSRI or SNRI, okay, like the fluoxetine 20 mg per day, or sertraline 50 to 100 mg per day. Citalopram can be used as 20 mg per day, and paroxetine, for example, 20. Side effect usually nausea, insomnia, fatigue, reduced libido. And how to discontinue the treatment: simply, if you use the luteal phase only, this can be discontinued at any time. If the woman is on the continuous regimen of SSRI, she need to stop it gradually, okay, to avoid withdrawal symptoms. Are we clear so far? Okay, so guys, again, let's have a look again, okay, on the treatment. So we have reached the third line of treatment. First line, remember, lifestyle modification, CBT, neuromodulator like SSRI, or for the woman who doesn't want to have a children now, we can use a combined hormonal contraceptive or combination between levonorgestrel and the esenyl estradiol for 3-4 months without a break. Second line is combination between SSRI and COC, or combination between SSRI and the estrogen therapy, estradiol patch plus micronized progesterone or the levonorgestrel. Third line is the GnRH analog, and be careful with the GnRH analog. You must add the hormone add back therapy. This is 6 months if you are using the 6 months, okay, and the form of use can be nasal, intranasal, or injection, okay. The fourth line of treatment, this again to reduce the fluctuation in hormone level. And the fourth line of treatment is a total hysterectomy plus bilateral salpingo-oophorectomy plus or minus HRT in refractory cases not responding to medical management. Okay, so can I offer surgery to treat BMDD? And I will not say surgery to treat PMS. I will say to treat BMDD. Yes or no? In severe refractory cases. Okay, so a case that have used first, second, third line and no benefit, I can use for her surgery. Okay, and we have a very famous station in the part 3 where the case comes to you and she requests surgery. Okay, after trial only of some lifestyle modification or shorter trial of hormonal. Okay, and she wants a surgery. So informed consent means discussion of the benefit and risk. This is very important, okay, for the patient to make her informed decision. Okay, so it's highly effective and well accepted permanent cure of severe PMS or BMDD. Surgery is beneficial if there are other indications for hysterectomy, as well as fibroid or hysterectomy is essential along with bilateral salpingo-oophorectomy, okay, in some other gynecological problem, okay? So this will be the best if the patient had other gynecological manifestation. So if it's not, if the patient doesn't have fibroid or HMB along with the BMS and BMDD, what we will do? Okay, so we have to counsel her. Counsel about what? Counsel about that the removal of ovary must be combined with removal of the uterus. Okay, why? Because if the woman had a uterus, okay, then we have to give her progesterone to protect the endometrium, right? And if we give her progesterone, that means we putting her again at the same risk of exposure to progesterone and converted into the body to the allopregnanolone, and this at the end, okay, lead to again recurrence of symptoms. So the evidence suggests removal of the uterus plus the ovaries, not ovary alone. Okay, so is it a person? Is it a one-person decision to take to remove just the woman ovaries and uterus because of the BMDD or BMS severe? Is it a one-person decision? No, no, no. Okay, this is a responsibility. This must be done by MDT. Okay, guys, this must be a MDT. This is very important. So the case in the exam who come to you to discuss the surgery and you discuss with her the benefits and the risk of the surgery, it will be a big safety issue and communication with colleague if you didn't mention the MDT. She must have seen by the MDT. Okay, so even if you tell her the information about the surgery, it's not your decision. Okay, it's the MDT decision. So very important, okay, that MDT will have a meeting together with the lady and they will decide what is the best to go through after counseling, okay, proper counseling. And then if there is any doubt, especially in younger women, it's helpful to undertake a GnRH analog plus estrogen only add back therapy, okay, test to ensure efficacy and tolerance of estrogen. Okay, because a woman after removal her ovary and her uterus, she will need HRT, right, to protect her bone, her cognitive function, her cardiovascular system, right? So she will need hormonal replacement therapy, and the hormonal replacement therapy will be only estrogen, right? So the lady will have the GnRH analog plus add back. What is the form of add back? Will offer her estrogen. Okay, so we give her this trial to check whether she will tolerate the estrogen or whether her symptoms is elevated. Okay, Once her surgery is done, okay, after the whole discussion and she's aware of risk and effect on infertility and risk associated with surgery, okay, then the patient will need to be on a longer term HRT until the natural age of menopause. And the HRT will be given to her will be in the form of estrogen alone. Sometimes can be with the testosterone supplementation. And the testosterone supplementation along with estrogen, this is to help with the sexual libido. Are we clear so far? Okay, so I guess most of you are aware of the, the basic management of the PMS and BMDD. What about the novel therapies? What about the recent uh, therapies and still under research? The therapies under research based on the theory, okay, of what caused the PMS and BMDD. So, do you remember? 1 second. I'll go back, sorry, in the presentation. Back. Yes, here is enough. Do you remember, guys, in the metabolism of progesterone to allopregnanolone, what was the first step? The first step was by the enzyme 5-alpha reductase. So it's logical, okay, that we use this information, provide 5-alpha reductase inhibitor, something to block this step. So we prevent the senses of allopregnanolone, right? Does it make any sense to you? Yeah, it makes sense, but it's still under research. Okay, so the use of 5-alpha reductase is still under research. However, okay, it's mentioned in the TUG article, mentioned in the chart. Okay, so if you've been asked about the drug, okay, that can be used, okay, or what agent can be used, we have the 5-alpha reductase inhibitor. Okay, that is tried. This is the dose of 2.5 mg daily. Okay, this is to reduce the luteal phase increase in the allopregnanolone. Okay, so this is one of the medications that is suggested, okay, to be the future of treatment of the PMS and BMDD. Another thing, okay, can be used is isoallopregnanolone. So what is the use of that? What do you think? What is the benefit of using the isoallopregnanolone? Yes, okay. So it can have a competition on this on the receptors, right? Yeah, okay. That's good. Okay. So we are our main aim of this treatment is to block the effect of the allopregnanolone, okay? And this can be achieved again, okay? This is a modern therapy, guys, okay? Um, if you are in a structured discussion, dear, you have to mention it. Okay, if you are in a structured discussion, we have to mention the new thing is still under research because the examiner wants to make sure that you have read the TUG article. Okay, you are updated. Okay, so reducing progesterone metabolism, okay, number one by the alpha 5 reductase inhibitor, okay, and there is, by the way, randomized double-blinded studies, guys, that have tested this effect. Okay, so it's not like just a treatment that it's an idea. No, they have started already, and there is a published randomized double-blinded study, okay, which means that this is a strong study have been done for it. Okay, so it can be used, and they have found benefit preventing the luteal phase increase in the allopregnanolone and significant reduction of the BMDD symptoms. So it's a good Okay, it's a good promising treatment. Okay, so antagonizing the effect of the allopregnanolone by using the isoallopregnanolone. Okay, so again, there was studies done, and it's double-blinded, randomized study, means again, it's a strong study, and it was placebo-controlled, tested the effect of GABA A, modulating steroid antagonist. Okay, this is called the cypranolone during the premenstrual phase in the woman with BMDD. This resulted in a considerable improvement in the BMDD symptom severity. Okay, so this is was a good also and promising result with the this drug, the cypranolone, because it worked. Do you remember the GABA? Do you remember the GABA and the glutamate balance? I'll go back to the picture. Do you remember this balance, my friends? GABA is red, so it stops the problem behavior, the problematic behavior. Okay, so if there is imbalance, which is found in those women by the research, so if I increase the GABA, okay, I can have a better uh, sleep, an anxiolytic effect, neuroprotective, uh, reduce neuroinflammation, and reduce the pain sensitivity. So that's mean much reduction or improvement in symptoms. Okay, so are we clear so far? Guys, have you got the idea of the new medication? Because to be honest, if you are having a new question in the theoretical exam, in the part 2 exam, you should be aware of these drugs. If you have a structured discussion, you should be aware of these drugs, because this is the update. This is based, as I told you, on randomized double-blinded trials. So it's not just a theory. It's now under treatment and given to the patient and proved efficacy, but it's not published in the guideline yet. Okay, so this is the future of the treatment. Okay, I hope we are clear so far in the theory why those drugs can be helpful and can be effective in the woman who have BMDD, right? So remember, it's all start from the brain, and we want to work on the brain level. Okay, trying to reduce the allopregnanolone and trying also to get the neurotransmitter GABA and glutamate in balance again. Okay, anybody have any questions so far? Okay, so what is this? What is this picture? Last thing. Are you familiar, guys, with this herbal medication? This is a natural tree, okay? And they have found that it's very promising result, okay, to make a balance between the balance of the female hormone, okay? This is called the Agnus castus, okay? So it's, of course, a very strange name for us, but however, it's very widely available, okay, in the herbal market in the UK. Okay, so this is under treatment still. So I have a woman in my counseling in the station of the PMS and asking me about herbal medication. What shall I say about it? This is a complementary therapy. It's a Vitex agnus castus, VAC. What shall I say? Data from the clinical study is still limited, and the studies are still okay, underpowered. Okay. Yes, yes. Okay, so we have a limited data from studies and still underpowered. Okay, simply that there is no enough evidence to say it's effective yet. Okay, however, ladies are using this, okay, off the label. And if you simply just search it, UK market for it, you will find so many forms available in capsules, tablet, powder, and everything. Okay, I think we came to the end of this talk article. Okay, now, and I think also I'm going to give you a break before we start the physiological breech delivery, okay, which is a new thing as well, or this new article is discussing the physiological breech delivery, which can be possible, of course, part 2 question and possible teaching station in the part 3 or structured discussion as well. Okay, guys, so in the break, I need you please all enjoy a break for 5 minutes, and then we'll come back 5 to 10 minutes. What do you think? Yes, sure. I'm happy to receive any questions. Please write your questions, and once we come back, I will answer it. Thank you very much. Okay, so 5 to 10 minutes. Don't go far. Thank you.
This conference will now be recorded.
Hello and welcome with the management of the term breech presentation. Okay, and this is a new TUG article which is published in the January 2023. And my friends who sent to me the algorithm of the TUG article, they were like confused. Oh my God, this is look very complicated to us. However, it's very easy. Okay, this TUG article is introducing for you a background information about the breech delivery, the term breech delivery. Okay, it's not discussing the preterm at all, which is in line with the guideline, the RCOG guideline, which is published in 2017. So it looked like, why do we have a TUG article? Okay, yeah, there is a difference here. Why there is a difference? They are introducing to you what is called the physiological breech delivery. And it's a simple way, okay, of delivery, more natural way of the delivery of the breech. And this is based on, um, observation of videos, okay, and pictures being done for women who had a vaginal breech, a natural vaginal breech delivery. So they have, introduced this way to adopt the natural way of the delivery of breech. Okay, and the person who have invented, this algorithm of the breech delivery or adopted this method, which is now widely distributed all over the world, is Sean Walker. And Sean Walker is a midwife in the UK. Okay, and however, this TUG article is published and using her algorithm. Okay, and she introduced that to us as members of the Royal College, that to find out how simple is it and how can we reduce the mortality and the morbidity from the cesarean section, okay, by adopting this as the way of management of breech. Okay, so let's go through the TUG article, and hopefully that the information, the background information in this TUG article is easy to use, so we will not spend that much time in it, but we will spend time in explanation of the physiological breech birth. Okay, so the epidemiology is the same, that around up to 5% of fetuses are in the breech position at birth. In the RCOG guideline, it was around 4%, no much different. Okay, and the rate of the vaginal births in the UK have steadily fallen since the mid-90s, and this is around 0.3% of all births. Okay. They have found among the 4% have been diagnosed as breech births, 10% only delivered by vaginal, and the other delivered by cesarean section. Okay. So this is the finding in the practice, in the current practice. However, in Europe, this is not the same. In Europe, in France, for example, they have found that the rate is 25%. In Netherlands and Norway, it's over than 30. Okay, in Norway, it's more than 30. Sorry. So it's why those people have more cases of vaginal breach and we don't. Okay, so this is a very big question, and this is the aim of the TUG article, is they are trying to teach the Royal College, trying to give you this message, guys, so all the member of the Royal College, the prestigious members of the Royal College, should be aware of this. Okay, so types of breach as we know it, as 65% is the frank breach, okay, and the frank breach most commonly when, as you can see, the joints, the hip joint is flexed and the knee is extended, okay. The complete breach is 10% when the baby hip and the knee joint are flexed both together. Footling breach or kneeling breach, okay, is incomplete breach type, and it's 1 in 4 or 25%. The footling breach, this is something that occur 10 to 40% of breech presentation and more likely to occur when the fetus is preterm. Okay, so the higher rate of the footling breach is considered as a preterm, and it's considered, okay, as indication for cesarean section in most of the protocols and the practice all over the world. However, again, the TUG article comes with some basic information or background information regarding risk factor for the breech presentation, nulliparity, Caucasian, ethnicity, congenital uterine malformation or multifibroid uterus, raised maternal BMI, oligohydramnios, polyhydramnios, and small for gestational age. Okay. What is the management of breech presentation at term? Okay, so we have out of 3, we have 3 manages, 3 things that we can offer the woman who have breech. Okay, so one is the ECV, one is the elective cesarean section, and one is the vaginal attempt of vaginal breech, right? So this is the 3 things that we all offering the woman who had breech at term, right? So in the ECV information, it is the same as the guideline, and they say that there is factor influencing the success of the ECV, like, for example, something that increases success, like high provider experience, multiparity, increased maternal age, and non-engagement of the breech, and the use of tocolysis before the procedure, low maternal body weight, and posterior placenta, complete breech, flexed breech, okay, which is, as you can see, it's most common. Amniotic fluid index more than 10. While the factors that decrease the success is nulliparity, maternal obesity, or extended breech, frank breech, or footling breech, right? The ECV can be successful in up to 50% of women when they have attempt, and the confirmation of presentation by the ultrasound immediately, after you finish the ECV is very important, and CTG before and after the procedure also is a very important. Don't forget the role of NTD when you have the ECV when a woman have RH negative, right? Okay, so this is the same information as the guideline. Okay, what is the difference in the TUG article? In the TUG article, they discuss with you that it could be up to 4 attempts at version within 10 minutes period. Okay, this should be considered the upper limit. And where a trainee is performing the procedure under supervision, later attempt may be conducted by more experienced operator. So the TUG article suggests that 4 attempts of ECV and even more can be done only by experienced operator. Okay, so this is the thing that came in the TUG article. The TUG article, my friends, is criticizing the term breach trial. So the term breach trial, which has been done in the 2000, okay, so that's mean 23 years from now, okay, but still its result is affecting the practice all over the world, okay. So there is here in the box number 2 of the TUG article criticism, okay, of the term breech trial. Number one, they found that there is lack of adherence to inclusion criteria, okay. So this is a critical appraisal of the study protocol, okay. So the protocol said that only live single tour fetuses should be included, okay. And what happened is that there was some cases that not okay fulfilling the criteria was included in the study. Over representation of macrosomia in the vaginal breech group. So they have found that the macrosomia, they have a lot of cases with macrosomia more than the natural or the population risk of macrosomia, okay. So presence of something like that, that's led to difficulty of the vaginal breech. So this has affected the overall result of the term breech trial. And also there was significant inter-institutional variance in standard of care, okay. So they didn't find that all the centers follow the same standard of care, which is of course something that, you know, if a place provide a optimum care is different from a place when they don't have, okay. Also presence of experienced obstetrician in the place. Some centers they have experienced obstetrician, some centers they don't, okay. So it's not the same, you know, quality of care that is being tested. And there was a relationship between mode of birth and cause of death, okay. So they found that some babies who died in this trial, in the term breech trial, was actually not because they have delivered by the breech. This was because other causes, but it's considered in the final result, okay, as association between the breech and, you know, the dead deaths of the neonates. So can you imagine if they have included 4,000, okay, and among the 4,000 the 200 died, for example, okay. So 50 out of them they died for other causes, because maybe infection, because maybe a genetic problem, anything, okay. But it was included at the end as rate of stillbirth in people or the infant delivered as breech, okay. So that's why everybody's scared to deliver vaginal breech, okay. And the numbers, the TUG article sees that the numbers or the study of the term breech trial should be revised, and we shouldn't depend on it, okay. And also there was some definition and the implication of morbidity, like for example they have found that a lot of cases that considered as morbidity, they are just doing fine after delivery, after some time of the delivery, so it shouldn't be considered as morbidity, okay. So this is the effect of the term trial. The TUG article also is say, okay, to use a moxa, as you can see, the moxipitation, okay. This is ancient Chinese therapy involving the burning dried the mugwort at the specified acupuncture point, okay, at the tip of the fifth toe. Sometimes also the woman should smell, okay, this. They have found that the Cochrane review highlighted the absence of high-quality trial data evaluating the efficacy of the moxibustion. However, there is knowledge that there is a reduction in non-vertex presentation and need for oxytocin and birth by cesarean section when the ladies had used this mugwort, okay, smoke, okay, which is called the moxibustion. So the RCOG guidance supports the use of it, okay, between 33 and 35 weeks of gestation to reduce the breech. Cesarean section. Cesarean section is the second option of a woman who had, okay, a breech delivery. So simply, you know, cesarean section is something that combined by risk to the woman, okay, more than the baby, considered more safe to the baby who had breech delivery, but it's higher risk to the mother and it can affect her future. Okay, so we don't comment much in this article about the cesarean section. Here comes the vaginal breech. Okay, the vaginal breech burst. Okay, actually the TUG article does not really, okay, um, like, okay, the current practice, and they suggest that we should depend more on the physiological breech birth, on the natural. Okay, so number one, a bright breech birth. Okay, so the mother should stay in the upright position. Okay, is associated with a significantly reduced need for maneuvers, neonatal birth injury, and shortening of the second stage by over 40% than the traditional supine positioning. Most birth attendants faced with the vaginal breech are unfamiliar with this approach because simply most of their teaching was involved demonstration on a mannequin, for example, okay, in the dorsal position. Physiological breech birth describe approach to vaginal birth centered on the optimization and restoration of the normal physiological process. Intervention, if required, is performed in response to specific clinical indicator, which are themselves based on evidence of what's considered normal breech delivery. Okay, so this is a point when the TUG article, okay, introduce a criticism, okay, of the current practice. Okay, so however, the RCOG, if you revise the guideline, you will find that the RCOG will advise the all four or the semi-recumbent, okay, position, okay, for the breech delivery. Okay, so my friends, what I need you to remember here in the physiological breech, that they suggest the upright position. And the upright position is a tool to enhance the physiological breech delivery, is not a rule. Okay, so may I ask you, it's a must that all women who have breech delivery to adopt the upright position? What do you think? What do you think? Will you agree? Is it a must, guys? No, it's not a must. Excellent. Okay, so it's something not a must. However, it's a tool. Okay, so it's something that can be used, and this is something that can, um, you know, uh, use it or promote its using for easier vaginal delivery, okay, breech delivery, and this is by the help of the gravity. Okay, so my friends, they have also based on their study or their observation here, they have found that there is stages of delivery of the normal breech, okay, of the physiological delivery of the breech. So if we look to the picture number one here, okay, this is, as you can see, how the breech is delivered. If I asked you, you know, the predominant point, the bony point or landmark that we use is the sacrum, right? Okay, so where is the sacrum in this baby? Number one. Is it sacrum anterior, posterior? Okay, so my friend, the number one, okay, will be the complete, okay, from the left to right. We can see, okay, starting by, okay, the sacrum is posterior, okay, and what happened number two? There was a rotation, and the rotation aimed to what? rotation aim to bring the sacrum anterior. Okay, so in normal vaginal delivery in the cephalic presentation, my friend, remember the aim of the rotation is to bring the occiput anterior. Okay, so what is the aim in the rotation in the breech delivery? The aim of the rotation is to bring the sacrum anterior. Okay, so this is a normal position. This is a good position, sacrum anterior. And they have found that if the baby during the delivery rotate, okay, the sacrum and become sacrum anterior, that this will be associated with less maneuver, less need of maneuver. So usually the arm will not be stuck, the head will not be stuck. Okay, so the sacrum anterior is the good position. Good, good. It's equivalent to the occipito anterior in the cephalic presentation. Okay, so if there is no rotation and sacrum stay transverse, the problem will be that here we need to help this baby, okay, in the rotation. Why? Because if this is not happen, okay, the delivery will be difficult. Okay, so in this case, we anticipate that there is a problem if we have sacrum transverse or no rotation of the sacrum. Okay, this is one thing. Another thing, when the baby physiologically delivered and by the help of the gravity, what they have noticed is that the baby normally flexes his body. Okay, if you can see here, okay guys, this flexion that I want to show you. Okay, so first the leg extended, okay, and then as you can see here, baby is making flexion in the body. You know what happened? He flexed all his limbs, including his head. Okay, so in the reflex flexion, okay, what happened normally is head get delivered in the flexion position. Okay, so this is good. Flexion is good. Okay, so I need you to remember, sacroanterior is good, flexion is good. When I have failed the rotation of the baby to the sacroanterior position, I have difficulty. I anticipate that there is difficulty in the delivery, so I offer help. When I have problem in the flexion, baby is not flexed, okay, during the delivery, then I anticipate that this is going to cause a problem, because that's mean head is not flexed. Okay, so if I didn't see the flexion action of the body of the baby normally, okay, in the upright position, I will anticipate that there is no flexion of the head. That means difficulty on the delivery, right? So this is the triggers to offer help. Are we clear so far? I hope it is. Okay, I hope it is. Okay, so I just want to show you in this video. You can listen to the voice in this video. Please let me know. Can you listen? Okay, can you hear the video voice when I turn it on? Okay, good. So no problem, I'll comment on the important point that I need you to find. Okay, so apparently this video is by, or this presentation is being done by the Sean Walker herself. Okay, so she's the one who invented this algorithm. And I inserted the link for you guys, and I can post the video on the group. So it's free and everybody can have it. So here she is defining the physiological breech birth as a breech birth is in which the woman is encouraged to remain upright and active throughout her labor and supported to birth in position of her choice. Okay, and she considered that the upright position is a tool and it's not a rule, so the woman can convert according to her preferences or according to the feel, the process herself of the delivery. And you can see here she have this woman, okay, this nice lady in the picture, if you can see it, and this is the baby, this is the breech baby staying inside and wait to come out. Okay, so with the help of gravity from down below and help of maternal effort from above, okay, like we can use the oxytocin, we can use the maternal effort, of pushing, okay, and she suggested some fundal pressure. However, the RCOG is conservative in this regard, okay, so the baby is going to come down easily, right? I'll explain the nipple line of the baby. Okay, I'll explain to you the nipple line of the baby. Okay, so it's not the mother. If you can see here, I'm sorry. I know that you guys take time when you write, so the question appeared to me later on or a bit delayed. Okay, so I want you to tell me, can you see this nipple line of the baby? Here. Okay, this is the nipple line of the baby, right? Can you see it, my dear Dr. Ifat? Okay, so this is the nipple line, and I'm going to explain to you if the rotation not happen when the baby reach to the nipple line, so that means there is delay in the rotation and we need to help. Okay, so I'm going with you one by one, trying to understand the normal physiological breach and what is the intervention that we will do. So the intervention that we will do is how to help this normal process to happen. Okay, but at the end of the day, it's normal. It's something that's not happened by us, by our intervention. Okay, I'm going back to the video if you think it's useful. Okay, so guys, in this video, as I show you, okay, the encouragement of upright position, and it's important. And again, okay, the woman doesn't want or not required to lie on her back during the breech delivery. Okay, so avoid this, please. Okay, the first principle of the physiological breech delivery is ensuring skilled and experienced professional attend the birth, and this has significant impact on the safety of breech, okay, birth. So number one is the human factor. Number one is that person who conducts the breech delivery should be experienced. This is the number one principle, okay? So okay, so the woman herself, okay, should understand that the upright position is to optimize the physiology, okay, and facilitate the woman's ability to birth her baby with maximum efficacy. Okay, so this is the number two. And then the safest breech birth exhibits optimum physiology. Okay, so when the labor begins spontaneously at or near term and progressive steadily, okay, there is no hand-off technique. Okay, so if you remember in the guideline of breech and the classic way of delivery of breech, we always say that we will leave the baby to be delivered by his own, okay, or her own, without touch, right? Hand off technique until everything is going smoothly. And when there is certain point of delay, we do our maneuver. This is what we know, right, from the guideline. What is the difference between the assisted vaginal breech or the breech delivery by the guideline and the physiological breech method? The physiological breech method is that no touch technique, okay? We can help, and the woman will be encouraged to push, okay? Whenever she feels the urge to push, she will push, okay? So, as you know, it's more physiological. So again, power from above is safer from pulling from below. This is the other principle. What is the power from above? It's oxytocin, okay? It's the maternal pushing contractions. And they, as I told you, they say that fundal breathing can be used, okay? So this is what is the power from above means, okay? So is either than you are assisting or doing maneuver from below, okay? Let the power come from above, means come from the maternal side, okay? So this is the options, oxytocin or fundal pressure or maternal effort. Clear, my friend? That's a very good question. If you're worried about the exam, okay, which one we will follow in the exam? We still follow the guideline of breech delivery. If you have a question about a delay, for example, and he described a delay in the breech delivery, then we have to advise the maneuvers, okay, that we've been taught in the guideline, and today I'm giving you a summary of it. But let's say I am in a party 3 and I have a teaching station, physiological breech delivery. If I described the breech delivery in the guideline, that's mean failure because I'm describing something else, right? Yes, I strongly agree, Dr. Osei, that the fundal pressure is something that the Royal College has a conservation, you know, it's very conservative in it and it's not advised. Okay, so, but guys, I'm describing another thing else. I'm describing a method, another method of delivery. So this is published in the TUG article, means that you should be aware of it. And by the way, the RCOG is starting to introduce a course of the physiological breech birth. Okay, so this is another way of delivery. Okay, guys. Okay, I have a good question here from Dr. Delhi. She's asking at what point is the attending clinician expected to intervene in the process and in the cord appears compressed or if the descent appears delay. Okay, I will describe to you there the algorithm. You have a very good question. Okay, at which point, at each point when there is a delay, what is the action? Okay, so in the physiological breech delivery, you should be active, okay, whether there is a delay, okay, or there is something not expected happen, okay. In the physiological breech birth, okay, a healthy uncompromised baby moves in ways which assist or has assist her or his own birth. So means that baby will expect to move, as I told you, in the direction of rotation, okay, to bring the sacrum anterior and then flex the body. The legs will be delivered by the gravity, so it will be in the extension position. And then he will, like, you know, have a small jump. He will have a flexion action, okay, to assist his delivery. Okay, so I want you to have a look here, okay, my friend. Take care, guys, of the action of the baby, okay? Movement of the baby. Can you see? Have you seen the flexion jump? Again. Have you seen this? Okay, so she is finding, okay, that this is what's recorded over their study, okay, and they have found that this is a normal mechanism of the delivery. This is a physiological mechanism that legs delivered by extension, and then the healthy baby is going, or in the smooth vaginal breech delivery, what will happen is this flexion, or trying to adopt again the fetal position by making a flexion action by his body, and this action will promote the flexion of the head. Okay, so this is a good one. And they have found that if the baby did not do this action, remained flexed during the delivery, that means the baby is compromised. Okay. See, arm by the flexion, because he's moving his body all in the flexion position, arms came down and head is flexed. So they see that if there was a delay in this action, that means that there is hypotonia in the baby, that if he didn't do the flexion action, and that means that the baby is compromised. So that means you should interfere or help faster. Okay, so here again, she emphasized on that upright position is a tool and not a rule, okay, for the physiological breacher. And the woman can change her position or change her body, okay, uh, that's to help, okay, the delivery of the baby in whatever position that she is comfortable with, or the healthcare find that this is can help. Okay, and I'm going to show you another video, okay, regarding the change of the position. So the woman adopted, okay, another position, okay, for the delivery. Okay, so it's not in this part, okay, the woman is not in the upright position, as you can see. Okay, so this is what you will find in the algorithm. This is the principle that Sean Walker actually described here, that maternal change of the maternal position itself, okay, can solve the problem of the delay in delivery, okay, and simply by changing mother position, delivery will become more faster, okay, right? So this is one of the intervention, right? So use of maternal movement and effort as a first intervention, okay, this is what she also suggests. Okay, so this is what she suggests, okay, my friend, and this is what we will discuss, okay, when we come to the algorithm and the explanation of it. Why? Because we have to understand what is the lady, okay, who invented this algorithm, how she think, and what is her recommendation, right? This is the best way to understand the algorithm and its application, okay? There is a very good picture. However, it need more of the understanding, okay, of the breech delivery and the maneuvers done in the breech delivery, okay, which I used in my presentation, okay, trying to bring you guys the definition, okay, that you will see, and what is the meaning of each maneuver of this. Okay, so I have used this table, okay. This is from the studies that they have made, actually, from the retrospective study, and the definition of maneuver, what is the meaning of it, because the most problem, okay, when we come to here, okay, for example, the understanding of the algorithm, you will find something like running start. What is the meaning of running start? Okay, what is the thumb to bum at nibble line? I don't understand. Okay, for example, okay, this is what is the shoulder breast, right? This is the way of difficulties that you guys found in the understanding of the algorithm, right? Isn't it? So I'm trying to explain to you what is the aim or what is the principle, okay? And then I'm going to discuss with you what is the maneuver they have used to deliver physiological, okay? And what is the meaning of each one of them. Are we clear so far? You agree with me? Okay, so the first maneuver, my friend, is the shoulder press. What is the shoulder press? Shoulder press is pressure just below the fetal clavicle to move the shoulder girdle back between the mother's leg to flex the aftercoming head in mid-pelvis or outlet. Okay, so a picture of it, and a picture is better than 1,000 words. Can you see here, guys? Can you see this picture of the shoulder press? This is in the teaching course. Okay, have you noticed the hand of the instructor? How she is applying the hand, okay? And what is the definition of a shoulder press? This is a pressure just below the fetal clavicle to move the shoulder girdle back between the mother's leg to flex the aftercoming head in the mid-pelvis outlet. Okay. Can you hear the voice of the video? Okay, so this is a very quick video and I'm going to explain it to you guys. So number one for the shoulder press, okay, is, as you can see, correct finger placement, okay, how to place your finger correctly, okay, on the baby back below the clavicle. Then you press straight back. Okay, so again, I'm going to show you this again, and you please notice the correct placement of the fingers along the lower distal aspect of the clavicle. Can you see the pressure, right? So this is a steady, continuous pressure, right? Okay, so by this action, when you place your finger correctly on the clavicle, okay, on the distal part, I'm sorry, again. So this is an applying a steady pressure, so you're helping delivery of the aftercoming head. Okay, lower distal part of the clavicle, pressing straight back, steady continuous pressure, and baby is out. Is it clear, guys, for you? Okay. Is it clear so far? What is the shoulder press in the table of definition? Number 1 in
Yes,
the
ma'am.
table. Okay, so the maneuver is the shoulder press. So just below the fetal clavicle, the distal, okay, part to move the shoulder girdle back between the mother's legs, and this is to flex the aftercoming head, okay. Sweeping down the fetal arm, this is manually stretching the maternal perineum, okay, as well. And fundal pressure, this is one of the maneuvers they have done, okay. Buttock left to assist shoulder press, okay. So the buttock left, this is lifting maternal buttock. So here we are moving the mother, okay, lifting maternal buttocks up towards the sacrum and sweeping the perineum over the fetal head, forehead, okay. There is also a maneuver that's called the modified Morsius Melevit maneuver. Okay, this is the modified Morsius Melevit. Okay, and this is by flexing the fetal head by elevating the occiput and downward pressure on the maxilla. Okay, rotational maneuver they have used to release the entrapped fetal arm. Okay, and they have also used this scoop and flex, which is internal flexion of the fetal head by sweeping one hand over the partial, of the parietal bone of the baby and pressing down on the forehead. Okay, this is what's called the scoop and flex. So, my friend, I want to show you another, okay, technique, which is the running start. Okay, so in the running start, what is the meaning of running start? Is like you can see here, this is the mother. What is her body position? What is the mother body position, guys, in the running start position? A running start position means it's like you tell the woman to run. Okay, so you know the runners in any marathon, okay, they adopt body position, okay, they lift one leg and they bring the knee, okay, up to the chest, right? So this is what you will ask the woman to do. This is what's called a running start, okay, and this is can be the first intervention that will help, you know, release. I'm going through the intervention with you guys, and hopefully that going through this is going to help you in the algorithm understanding, right? So before we go to the algorithm explanation, have you got the idea behind that? Have you got what is the physiological breach and what kind of intervention we can do? If you have any questions so far before we start explanation of the all of the algorithm, I'll be happy actually to explain it. Okay, so we have a lot of videos, my friend, as well, that to help you understand more the how to deliver using the physiological breech one. Okay, and this is one of these videos as well, like for example here, but this woman, she's adopting another position other than the upright. Okay, and you can see that she can change her position, okay, during the delivery, and whatever position she can adopt to help the delivery is acceptable. Okay, so the upright is the one first, but it is not the only. Okay, so as you can see, the woman is moving, okay, in the delivery. I'm sorry for the pictures, okay. The woman is moving through the delivery, and this movement is to help, okay, whatever position is to help, and it's considered the physiological will be the first thing that we will do. Okay, so let's go through the algorithm and try to go through one by one. Here, my friend, you have a lady in labor. Okay, what is expected in the time? Expected from both buttocks visible on the perineum between contraction that the delivery should not take more than 7 minutes to complete. Okay, so from the time of both buttocks visible on the perineum, so what we expect, 7 times to deliver. Otherwise, more than this, it's a delay. Birth of the pelvis, so means 5 minutes. More than this is delay. Birth of the umbilicus, so how many minutes should be till the delivery?
Ma'am, 3 minutes, ma'am.
Yes, 3. Excellent, Dr. Manikam. So we have 7, 5, and 3. Okay, this is the stages of the delivery and the time that they suggest. Okay, since we have a steady progress and reassuring fetal heart rate, we are happy, right? Do you agree with me that we are happy if we are following this? Progress is fine, 2 minutes between both buttocks visible on the perineum, between contraction till the birth of the pelvis. Yes, everybody is happy. But if not, what we will do? If not, here comes in the brown section, okay? So if not, then encourage spontaneous maternal movement. So what is the first intervention that we will do in the physiological breech? Encourage spontaneous maternal movement. Okay, my friend? Again, what is the first action when you suspect delay? It's encourage the movement, maternal movement. And by encouraging the maternal movement, a lot of deliveries or a lot of the, form of deliveries that can be normal after this and everything go back to normal and everything is fine. Okay? So maternal movement is very important and very valuable in this physiological way of treatment of breech delivery. Secondly is to advise a woman to continuous pushing, okay? Advise a woman to continuous pushing. And continuous pushing is to help bar from above. And bar from above is more safe than pulling from down, okay, from below. So if everything is okay till this stage and we have improvement in the progress of labor, okay, so perineal sweep and or episiotomy to help with the delivery. Is it clear so far? Is it clear so far, guys? So this is at the first stage when the buttocks visible on the perineum between the contractions, okay, and we don't have a steady progress or there is a problem in the fetal heart rate. So encourage spontaneous maternal movement, okay, and continuous pushing, and if everything is good, go to the perineal sweep and or episiotomy. Okay, good. Okay, so let's say we have birth of the pelvis, okay, the pelvis is delivered. So remember, what should happen to the sacrum? What should happen to the sacrum? Sacrum rotate and rotate to what position? To the anterior. Okay, good. So this is a good position. We are happy. Okay. So the baby tummy is toward the bum of the mother. Okay, so that's mean at the nipple line. At when the baby reaches the nipple line, his tummy is towards or facing the bum of his mother. Clear? Okay, so this is should happen normally physiologically at the nipple line. And if this happen, the rotation to anterior, sacrum anterior, happen when the baby reaches at the nipple line, we expect that this birth will be easy and the spontaneous birth expected. Clear? Are we clear so far? Okay. But unfortunately, my friend, if there was incomplete rotation, that's mean it's a sign for you to expect that this delivery will face a delay, right? We said if there is incomplete rotation, okay, or the sacrum is transverse, then we should do something, right? Are we clear so far? So this is the principle of the physiological breech delivery, right? So can you see the picture when there is no rotation and sacrotransverse? Baby stayed in this position. After here is the baby nipple. Can you see baby nipple? Baby nipple passed and no rotation happened. It's still in the sacrotransverse. What shall I do?
Ma'am, ask the mother to move.
Okay, so there was, yes, excellent. In the first, when the buttock, okay, was up and the pelvis not delivered, mother movement and encourage of continuous delivery, of the continuous pushing, right, to help the delivery. But now there is another action that we will ask the woman to do it. And yes, you are correct, Dr. Manikam. We will ask the woman to do something. What is this? They wrote in the algorithm running start. What is a running start? It's again, running start means that the woman will lift her leg, in this case, knee to the reps, okay? Knee up to the chest, okay? And putting the foot flat on the bed. Clear, my friends? So there is no rotation, incomplete rotation, sacrum transverse. This is all the same meaning. This is here, incomplete rotation. So running start is again mother action, right? So we are doing the first steps by the help of the mother, okay? So sweep down pubic arm, okay, on side baby face. So when you do the running start, okay, then this will lead to, better, diameter of the pelvis. So you can sweep the pubic arm of the baby, okay, and on both sides of the baby face and deliver the arm. Is it clear so far? Clear so far, guys? So I can use the running start when I have incomplete rotation and then help sweeping the arm. Clear. Okay. So there is another situation like no rotation, pelvis and shoulder remain in the anterior posterior diameter. So what I will do now, the pelvis and shoulder remain in the anterior posterior diameter. I try rotation here. Okay, I will try rotation myself, and I will try when I rotate the baby to release the pubic arm and rotate back to deliver the other arm. Clear? What about the problem comes in the head? The fetal head extended at the pelvic inlet in the anterior posterior diameter. What is the action that I will do? I
I'm
can
pressing the
elevate
shoulder,
the
ma'am.
occiput. The shoulder comes here, okay, when it's deflexed or delayed, okay? So the shoulder breast comes, okay, in the second one. Here, guys, I'm in this, okay, 1, 2, 3, 4, 5, in the section number 5, in line number 5 of this algorithm, okay? So it's elevate the occiput and rotate, okay? Trying to elevate the occiput by yourself and rotate with the support of your hands. Guide the head into the pelvis and realign. Okay, so this means that I'm going to do a gentle, sweeping myself, right? Yes, you do. Okay, so what if you have the fetal head in the mid pelvis or outlet, but it's deflexed or delayed? If the fetal head in the mid pelvis or outlet, but it's deflexed head, or there is delay in the delivery of the head, which we call it a head. When the head is stuck, what we call it? What we call it? Yes, entrapment of the fetal head. Okay, so here what I will do in the physiological breech, I will do shoulder press. Okay, how to do the shoulder press? Fingers below the clavicle. Easy, right? So guys, we have seen the shoulder press here. Is it clear? This is for the aftercoming head. When the head is stuck, when the head is entrapped. Okay? So pressure again by the shoulder press to release the aftercoming head when there is delay, okay? Or the head deflexed in the same time. So shoulder press, okay? And I can help also with the some below clavicle, okay? And then I will try to rock the fetal head to deliver. If not immediately effective, what shall I do? If not immediately effective, what shall I do in this case? Maternal buttock left. Then scoop and flex forehead. Okay, so I need you, my friend, to go to the sequence with me. I have delay of delivery of the head, deflexed or delayed, or aftercoming head of the breech. What is the action that I will take? What is the maneuver called? Shoulder press. Excellent. Okay, I'm trying the rocking fetal head, but if not immediately effective, then I will go again to the mother. I am going to ask the mother to help me. Okay, and what will I do after this? Maternal buttock left. Okay, so by the maternal buttock left, I am going to help the delivery, right? In the definition of maneuver, okay? The buttock left to assess the shoulder press, lifting maternal buttock up towarding the sacrum, sweeping the perineum over the fetal forehead. Next is the scoop and flex. Scoop and flex is internal flexion of the fetal head by sweeping one hand over the parietal bone and pressing down on the forehead. Okay, so guys, the two actions that I need to take is please remember it's buttock left to assist the shoulder press and then scoop and flex. Okay, are we clear so far? Okay, so here in the picture, and this picture is by, again, the same author, okay? So here, she is giving you the algorithm, okay, or the maneuvers that you can do and the intervention by your head. Okay, so here, my friend, is example of the delivery when the head is extended, okay? And this is how you can hold the whole body of the baby trying to rotate, right? And here is trying to correct the extended head. Okay, yes, and this is you're trying the shoulder press, and in the same time you're trying to change position even with the buttock, okay, left. You can also ask the woman, okay, to change her position or the hip left as well, okay. And finally is the scoop and have you forgot? Flex, scoop and flex. Okay, yes, okay. So you are doing this by your hands. Where is your hand? In this maneuver, this is the hand by the blue color. Your hand is inside. You are trying, okay, your maximum to bring the head, okay, flex it and deliver. Okay, guys, so this is the sequence of maneuvers that you can use, okay? So back to the algorithm. I hope that it's clear for you guys. It's easy, but I think my own comment or my own judgment that what caused confusion to the candidate, that number one, it's different from the assisted vaginal breech. Secondly, it's the language that being used or description of the positions or the maneuvers is somehow difficult. And in the TOG article, they didn't mention any of these, okay? They didn't explain the maneuver, they just give the algorithm, okay? And leave you try to understand it, okay? So the effort that we have made is and I must thank you, Dr. Nada, actually, that she helped me with some resources in my preparation, really, that to provide you guys with the maneuvers. Number one is from the definition, okay, and this definition is from another article, the study, the original study that been published, okay, in the physiological breech delivery, okay. So it's coming ahead from the people who made the study, and also from the trying to help you, okay, from the videos that to understand or to get the view of the physiological breech delivery, okay. So again, my friend, you will not understand this algorithm without understanding what's the normal physiology of the breech delivery that they have introduced to you, the Sean Walker introduced to you, and what is the maneuvers that you can do if there is delay in this physiological progress. Okay, so remember, my dear friend, again, if there is a steady progress, everything is okay, no intervention. Okay, quiet and calm and warm support. If there is a problem in the delay or a problem in the fetal heart rate, okay, and we are still at the level of buttocks visible on the perineum between contractions, then encourage the spontaneous maternal movement. And this is the first intervention, okay, that we can do. Then advise continuous pushing from the mother, because they believe the power from above is much safer from pulling from below, okay. And then for the delivery, perineal sweep and or episiotomy. If the rotation happen, okay, so this, we have passed this stage, and the rotation to the sacrum anterior, which is a normal physiology, happen when the nipple line of the baby appeared. So everybody is happy, and we expect that the spontaneous birth is okay, okay. And if there is incomplete rotation, then running start, and the running start is a maternal position, okay. She is like a runner, okay, to take the position, left the leg and bring the knee to the reps, okay, and her leg should be supported on the bed, okay. So if this was helpful and the delivery was fine after that, then this is enough. Then we come to the, if the no rotation and pelvis and shoulder remains in the anterior posterior diameters, then I will try to do rotation using flat hands, okay, with a good shoulder grip. And I will try to release the pubic arm and rotate back. I hope that this step is clear in the picture. Okay, so you can see in the picture using the flat hand and trying to rotate the body. Can you see here, guys? Yes, well done. Okay, so then release the pubic arm simply and rotate back. If the fetal head is extended at the pelvic inlet in the anterior posterior diameter, so try to elevate the occiput and rotate, and guide the head into the pelvis and realign. So again, okay, can you see here when they are trying to correct the extended fetal head? Okay, so can you see? They are trying to correct the position and bring it to the flexion. Okay. Then, I'm sorry. If the fetal head in the mid-pelvis or outlet, then deflexed or delayed, so the head is entrapped, okay, or it's aftercoming head. If the aftercoming head, then it's a shoulder press below the clavicle, okay, and the shoulder press and trying to rock the baby head, okay, is very effective. However, if it's not, you can help by changing maternal position or maternal buttock left, okay, if she is in the supine position. Okay, so can you see here, okay, woman in the upright position in this delivery, you can see, okay, and this is the shoulder press, and here is a rocking movement in this picture by Schomwalker. Okay, so this is a rocking movement and you're trying with the shoulder press, okay, to deliver. Then if the not again, finally not relieved, then scoop and flex forehead, okay, and the scoop and flex forehead, as you can see, this is your making your hand like scoop, okay, and trying to flex the head. I hope it's clear so far, the maneuvers, and I hope it's easy now to understand. If all failed, then we can use the forceps finally. And if we use the forceps, then the mother, okay, should be in the lithotomy position. Okay, in the TUG article, they suggest for the physiological breech, okay, to use any forceps, including the Wrigley forceps, okay, or the Keeland forceps. However, I need you to remember in our delivery and a breech delivery, the guideline, they have advised to use the PIPA forceps more appropriate. Okay, and if not available, then we go to the Keeland. Okay, my friend. I hope it's clear so far. Yeah, thank you very much, guys, for your time and for attending today. I have tried my best, actually, and maybe this is not enough, but I have tried really to simplify this algorithm for you guys and to bring, you know, this update and this trend in the management of breech delivery, the physiological breech delivery, okay, to you in understandable manner. Don't forget, this is a very important article now, okay, because I told you this is another trend and this is a new course that now published, you know, the college now announcing a course about the physiological breech delivery, okay. So and also can be interesting if you want to perform a breech delivery in your own place. However, my friend, you will find in this summary, when I post a summary, you will find summary of the maneuvers that we do from the guideline. Okay, it will be useful for you if you want to compare both of them to each other. Okay, what is the actions according to the guideline? But I don't want to discuss it now in order not to confuse you. Okay, so the day is for the physiological breech, so make it for the physiological breech. Thank you very much. Thank you very much, Dr. Maisa. Thank you very much, Dr. Bina, Dr. Aisha, all my lovely friend, Dr. Laila, and Dr. Ghada, Dr. Nihal, and Dr. Map, and Dr. Usay. Thank you very much, and Dr. Aisha. Thank you very much, all my friends. You can't imagine, okay, that really, really, I'm so happy by your feedback, and I'm so happy by your encouragement. Okay, thank you, and we'll see you in the next session next week discussing update. Thank you very much.